Thank you, Krishnendu, for giving me this opportunity. Well, I will be speaking on the role of electrophysiology in macular disorder. Yeah, electrophysiological tests are confusing. We are not very sure what test to be advised in which conditions. There is a test armamentarium which consists of ERG, pattern ERG, EOG, and multifocal ERG. Now, why this test? ERG, it reflects the function of the photoreceptors and the inner nuclear layer of the retina. The pattern ERG actually is a screening test when there is a confusion between the macular function or optic nerve dysfunction. So it actually differentiates whether it's a macular dysfunction or an optic nerve dysfunction. And EOG, it examines the RP function. And lastly, which is the most important diagnostic tool for a macular disorder, is a multifocal ERG, which actually analyzes the local retinal function. Now, coming to the basic ERG, the waves what we are concerned is the A wave. The A wave is derived from the photoreceptors, and the B wave, what we get over here, is derived from the bipolar cells. Now, all the electrophysiological tests are based on the ISF guidelines, that is the International Society of Clinical Electrophysiology of Vision. Whatever test we do, we need to maintain certain criteria laid down by the ISF. In ERG, in the beginning, we need an full-field ERG. Pupillary dilatation is mandatory. After that, we record the rod response and the maximum combined response, that is rod and cone response. Following that, there is a 10 minutes of light adaptation. Then the single flash cone response, 30 Hz flicker response, which is also gives a cone response. And lastly, the oscillatory potentials. Now, what is the standard response? If we see the rod response in the first curve, we should be aware of the waveforms rather than focusing on the absolute values of the amplitude and implicit times. So this is the rod response looks like this. The combined response is this. And oscillatory potential, we get a waveform like this. And cone response, we have a little bit different waveforms. And 30 Hz is that 30 Hz flickers looks like this. So we should be aware of the kind of waveforms we get. It depends on a lot of factors like stimulus duration, stimulus interval, pupillary size, medication, and age of the patient. Now, in different conditions, how the ERG looks like. As we are discussing in the earlier slide, the normal response looks like this as the topmost picture. In congenital stationary night blindness, we can see the rod response absolutely flat. And a standard combined response, what we get is just the opposite what we get in a normal. That's called a negative ERG. And cone response may be normal or a subnormal response. In retinitis pigmentosa, the rod response is flat. Standard combined response, sometimes we get a negative response or a flat response. And later on in the retinitis pigmentosa, we get a cone response also flat. So in full field ERG, mostly in the RP patient, we get a flat response, especially in the full field ERG. So that there is a need for the multifocal ERG in these cases. In achromatopsia and the cone dystrophy, as we can see, the rod response and the combined response is almost normal. But what is abnormal is the cone response, which is flattened out. Now coming to the EOG, indication is limited. It gives an information about the receptor pigment epithelial complex. What we need to see is the Arden ratio. If the normal value is greater than 1.8. If it is less than 1.8, then we diagnose the Best disease. Now, pattern ERG, as we were mentioning in the first slide, it actually helps us to screen sometimes when we have a confusion whether it's a macular dysfunction or a optic nerve dysfunction. The pattern ERG actually helps a lot. The first waveform, which is called the positive wave, that is P50, which comes at 50 milliseconds. If there's abnormality in P50, so there's a macular dysfunction, and we straight away go for a multifocal ERG. And if there's something wrong with the N95, then it's an optic nerve dysfunction, and then we have to do a VEP. Now coming to the multifocal ERG, it is an advanced technology based on the standard ERG what we were discussing previously. It measures the electrical activity from the different retinal location. So we get a focal response, and it produces a topographic map of the ERG responses from the central 40 to 50 degrees and analyzes the local retinal function. According to the ISF guidelines, pupillary dilatation is required, but here the 15 minutes light adaptation can be done in a room light, application of electron, and we need to monitor the fixation. This is the flicker sequence, that is the M sequence by which the retina has been stimulated to get the MFERG response. Now coming to the origin of the waves, how does it differ from the standard full field ERG? Now instead of an A-B waves, what we have over here is an N1 and a P1 wave. What is N1? N1 is an A wave of full field cone ERG, and P1 is a B wave and oscillatory potentials derived from the on and off bipolar cells. What we have a first order kernel reaction and a second order kernel reaction. Mostly practically what we use as a first order kernel reaction. Second order kernel reaction has a strong contribution from the cells in the inner retinal layers. Now this is the overview of a multifocal ERG. This is the M sequence, which stimulates the eye, and we get an 103 focal ERG. This can be more or less according to the program. And what we get a hill of vision. We can get an idea how which area of the retina is not functioning. And this is the ring response. Now, clinical application of multifocal ERG in acquired diseases. In diabetic retinopathy, even without retinopathy, when the retinopathy has not started, the amplitude is reduced. The inner retinal impairment occurs before the outer retinal dysfunction. And there are studies which has proved that absence of macular oscillatory potential in CSME. That is in full field ERG, obviously. In diabetic retinopathy, the oscillatory potential amplitude reduction predicts the progression from non-proliferative to proliferative diabetic retinopathy. And there is a study by Han et al. Which actually there is a prediction of diabetic retinopathy through multifocal ERG implicit time, duration of the diabetes, and the blood glucose level. The sensitivity 86% and specificity of 84% of predicting the size of future diabetic retinopathy in 12 months. Coming to the CSR, if we clinically see a single eye having a serous detachment, the other eye absolutely normal. But if we do a multifocal ERG, what we see is a widespread area of retinal dysfunction compared to the localized subretinal fluid. Even the fellow eye has an abnormal multifocal response. So it actually gives an objective measure of the retinal function. Sometimes the patient, the fluid is, it has gone, there is no serous detachment, but still the vision is low. So it gives an objective measure of the retinal function. In CRVO, the reduced P1 amplitude and the delayed P1 implicit time in the affected eye and the fellow eye. And a central P1 MFERG amplitude is a good predictor for a neovascular complication in CRVO case. In cases with the epiretinal membrane, as in the OCT, we could see the ERM in a OCT before and after the surgery. But sometimes before and after the surgery doesn't explain the visual prognosis. After the surgery, the ERM is not there, but still the vision is low. Here comes the role of the multifocal ERG for the better understanding for the patient as well as the physician, which actually gives an idea how the retina is functioning after the removal of the ERM. This is applicable for retinal detachment as well as the macular hole surgery. But the most important application for a multifocal ERG is the drug toxicity, and the most common among the drug toxicity is a chloroquine and hydrochloroquine toxicity. One of the criteria, one of the tests based on which the toxicity has been detected is a multifocal ERG in a very early stage, which doesn't come in the clinical, we don't see any clinical features. Still, we find the multifocal ERG finding in those patients. We have a characteristic gutter-like appearance in the hill of vision in the topographic map. We can see there is a gutter surrounding the foveal peak. This is very typical of a hydroxychloroquine toxicity. Other medications which are responsible for the retinal toxicity are vigabactrin, amiodarone, sildenafil, ethambutol, and tamoxifen, which is used for the breast cancer patient. Commissuretine also explains why the vision didn't improve in spite the retina looks normal. If we do a multifocal ERG, as we can see in this picture, this area of the retina is non-functional. So that is the reason the patient is not getting the full vision, which actually gives an idea of the irreversible damage to the photoreceptor. Clinical application of multifocal ERG in hereditary and congenital retinal diseases in the Stargardt macular dystrophy and the fundus flavimaculatus, full-field ERG and EOG are not useful in detecting the early stage. MFERG is useful for detecting the central retinal dysfunction. Same with the Best disease. Obviously, in the Best disease, EOG gives a lot of findings through the Arden ratio. And X-linked retinoschisis, as we were discussing the full-field ERG, we get a negative ERG and absence of second-order kernel reaction in multifocal ERG. Retinitis pigmentosa, as we can see, the full-field ERG is flat almost in all cases. But in multifocal ERG, what we see, if you see the central response, these are the first three waves comes from the central retina. It's 5 to 10 degree, 10 to 15 degree. The central part of the retina is still functional in retinitis pigmentosa. The clinical application of multifocal ERG in monitoring of treatment for retinal diseases, we see the improvement in the parafoveal MFERG response after PDT for CNVM due to AMD, provides objective assessment of the preoperative and postoperative macular function in patient undergoing the macular hole and the ERM surgery. It can investigate the changes in retinal function before and after the retinal surgery, retinal detachment surgery, and it can assess the retinal function after the transplantation of the autologous RPE cells and retinal prosthesis implantation. So in conclusion, the MFERG P1 wave of the first order kernel reflects the outer retinal response. The second order reflects the inner retinal response, and in clinical practice, it evaluates the macular function, detects the local retinal disorder, and estimates the therapeutic effect of surgery or any medication. Thank you.